Now we have Dr. Rajan Patel. He's from Oshner, and he would be followed by Dr. Amrish Satvik. And Dr. Rajan Patel is a cardiologist. I think he's the director of interventional cardiology at Oshner Medical Center in Louisiana, New Orleans. That's probably, that's the place where I also trained, and I was a fellow once in Oshner Medical Center under Dr. Steve Ramey, Chris White, and Ty Collins. So welcome, Rajan, and we would definitely like to hear your talk about limb protection during mechanical circulatory support in cardiogenic shock.
Thank you for the kind introduction, Dr. Khanna. I'm also a former fellow of Dr. Tyrone Collins, Chris White, and Steve Ramey. So I'm your brother in a sense. Thank you for the opportunity to present at the 13th Annual Asia Pacific Vascular Intervention Conference. This evening, I'm going to discuss limb protection during mechanical circulatory support for cardiogenic shock. Mechanical circulatory support is something that is being adopted more and more frequently worldwide, and due to the large bore access, this is turning into a serious issue. So as most of you know, early implementation of mechanical circulatory support has been shown to improve outcomes in acute myocardial infarction patients with cardiogenic shock. Dr. Basir and O'Neill have shown this in the National Cardiogenic Shock Initiative, and others have published similar data, such as Dr. Tehrani and Truesdale in the Innova Hospital Experience. The most commonly used mechanical circulatory support devices are, of course, the intra-aortic balloon pump, the Impella device, the Tandem heart system, and the VA ECMO system. Unfortunately, all cardiogenic shock patients are at increased risk for acute limb ischemia due to the factors listed on this slide. Everyone remembers Virchow's triad. By definition, all cardiogenic shock patients have stasis, as they have a low flow state due to LV pump dysfunction. Once a mechanical circulatory support device has been placed in the vasculature, by definition, endothelial injury has occurred. So 2 of the 3 factors are present for clotting. Among the ischemic cardiomyopathy patient population, there is a reasonably high incidence of peripheral arterial disease. So even before the onset of shock, these people's limbs are compromised. And of course, when in cardiogenic shock, systemic vascular resistance is very high, further limiting perfusion to the distal limb. And then when large bore access is placed in the proximal arteries, distal artery perfusion, of course, decreases. So again, these patients who are in cardiogenic shock are at high risk for acute limb ischemia. And so the importance of limb protection in cardiogenic shock is critical. One, for patient survival. If limb ischemia does occur, then the metabolic acidosis that the patient is already suffering from poor LV function, hypoperfusing end organs, will become worse due to the leg muscle becoming ischemic. Furthermore, if left untreated, the patient may develop a compartment syndrome. So even if the patient survives the cardiogenic shock, they may require a fasciotomy, which can lead to significant disability, which may be permanent. And then in the worst case scenario, if the limb is neglected, it may lead to amputation, which is very tragic if the patient survives the cardiogenic shock, but then leaves the hospital with only one leg. This slide summarizes the various mechanical circulatory support devices, along with the French size of the sheath that's needed to place the device or the cannula associated with the device in the arterial leg. The third column describes the reported incidence of limb ischemia in the literature. More contemporary studies with the balloon pump list a limb ischemia incidence between 1/3% to 1%. The higher percentages are from older studies which used larger sheaths to place the balloon pump. In contemporary studies with the Impella CP, the 14 French device, the incidence of limb ischemia ranges from 0.1% to about 10%. The same is true for the Tandem heart device, which uses a 17 French arterial return cannula. Now, of course, VA ECMO uses much larger cannula, and the incidence of limb ischemia is significantly higher. With regard to amputation, multiple studies have listed an amputation rate with the balloon pump from about 0.1% to 1%. And the incidence of amputation with venous arterial ECMO is about 1%. There have been, to date, no large studies examining the amputation rate with Impella CP devices or tandem heart devices. But those of you who have considerable experience with these devices know that any large bore access can induce ischemia, and if left untreated, can lead to amputation. So caution is certainly warranted. The keys to prevention of limb ischemia are limb perfusion systems to be placed at the time of MCS initiation, but most importantly, early recognition and treatment of acute limb ischemia. Here's a patient who was transferred to our hospital, a 22-year-old woman in 1 week postpartum with postpartum cardiomyopathy and cardiogenic shock. Her cardiac output was about 1.5 on 4 pressors. Her lactate was greater than 12 milligrams per deciliter, and her pH on arrival by helicopter was 6.9. The heart team immediately decided the quickest way to support this patient would be to place a left-sided tandem heart system. So as most of you know, this involves a 21 French transeptal cannula to draw blood from the left atrium and return it via 17 French arterial return cannula. This angiogram shows a 6 French sheath that was placed in the left common femoral artery using ultrasound guidance. The 6 French sheath is completely occlusive, and if you look carefully where the yellow arrow is pointing, you will see that the profunda femoris artery is filling via collaterals from the internal iliac artery. Here's an angiogram slightly higher up. You can see that her entire vascular system is constricted. Her calculated systemic vascular resistance was around 3,000 at this time. So the 6 French sheath was occlusive. Certainly the 17 French arterial return cannula would be occlusive. So before placing the large bore access, micropuncture using ultrasound guidance was used to place a 6 French antegrade sheath through the common femoral artery such that the tip is in the superficial femoral artery. And this braided sheath was then connected to the sidearm of the 17 French arterial return cannula to make sure that the patient's left leg was perfused while on support. So this woman required almost 3 weeks of support before her heart recovered and the tandem system was weaned off. She was brought back to the cath lab for removal of the tandem system using a balloon tamponade of the artery. And although there's a non-flow limiting dissection here, you can see that her arteries, now that she's no longer in shock, are significantly larger in caliber. So this patient actually was discharged a couple days after this and is doing well at home. Many of you who attend this conference are experts in the treatment of critical limb ischemia, and we more and more frequently use pedal access when treating patients with critical limb ischemia and severe infant inguinal disease. We use ultrasound access to gain pedal artery access, and the same type of sheath that we use during interventions of the pedal artery can be connected to a blood pump, the active pumps, such as the tandem heart pump or a side port on the ECMO circuit to perfuse the leg in retrograde fashion from the foot up. So this is also an option for patients undergoing large bore access for mechanical circulatory support. The Impella is different in that the pump is internal, it's not external to the body, and the pump draws blood from the left ventricle and pumps blood into the aorta. So this is the angiogram of a patient with an acute MI in shock who was about to undergo Impella placement. The 6 French sheath, as you can see, is smaller than half the diameter of the vessel, but certainly a 14 French sheath would be occlusive. So we needed to protect this patient's limb also. And the way we do that, again, is to place one of these 6 French braided sheaths in antegrade fashion using ultrasound micropuncture guidance before placing the large bore sheath. And then the sidearm of the 14 French Impella sheath is connected to the sidearm of the antegrade 6 French sheath, and the limb is allowed to perfuse passively as opposed to with the tandem and ECMO systems where active pumping of blood is done down the antegrade sheath. And this allows the protection of the limb. More recently, Dr. Licha has described the lend-a-hand technique, in which a sheath is placed in the ipsilateral radial artery to the leg in which the Impella system is placed. And then the radial sheath is connected to the antegrade sheath, thus allowing blood from the radial artery to perfuse the leg. One of the important cautions using this technique is that the patient's hand must be restrained because, for example, if the patient were to reach for his or her head, for example, to scratch their nose, they could pull out the antegrade sheath. So it's very important to be careful using this technique. And this is hot off the press from Dr. Malikathi Reddy, using impeller sheath modification. So this is an impeller 14 French peel away sheath in which these two punch holes have been placed in the intravascular segment of the sheath. Therefore, blood can enter the sheath as it would normally do. And instead of being occlusive, the sheath has these holes that allow the distal limb to perfuse. How is this done? How do you figure out which part of the sheath is actually in the artery? You can either use a Perclose device or, as shown on this slide, an angioseal device, and measure the length of the tissue tract from the top of the device to the part of the device that is actually in the skin. And as shown on the right side of the slide, you can see how this measurement is made from the hole in the angioseal device to where the mark is. Then this mark is then put on the impeller sheath, and then 5 millimeters distal to that mark, 2 holes are made using a biopsy punch. And then the peel away sheath will allow the distal limb to perfuse. But even more important than any of those techniques are early recognition of acute limb ischemia when that happens. And the best way to do that is to protocolize care in the ICU. So all the people working in the ICU are trained to take care of these patients and be alert for acute limb ischemia. This means checking and documenting the distal pulses every hour, assessing limb color for perfusion every hour, and training the ICU team not only on how to assess the limb, but what to do if acute limb ischemia is detected. Calling the intern or the most junior doctor in the hospital on call in the middle of the night when acute limb ischemia is detected will not end well, because that doctor has lots of things to do and will only have to escalate the call to another physician, which will delay time of care. So calling the more senior physician, an interventional cardiologist, a surgeon who can actually do something to address the acute limb ischemia is important. Just a word of caution, knee immobilizers are being used more and more with patients with these devices, but if these immobilizers are placed too tightly in patients with non-pulsatile flow, they can cause limb ischemia. So in our hospital, we've stopped using these devices. And then more recently, reports are being published using automated systems that take out the subjective aspect of assessing limb ischemia. Here's one example from Edwards that uses near-infrared light system spectroscopy. One detector is placed on the leg with the MCS, the other detector is placed on the contralateral leg or arm, and the computer will compare the tissue oxygen perfusion between the two and alert the nurse if there's a significant difference. So in summary, the incidence of acute limb ischemia among patients with MCS for cardiogenic shock is not trivial, and the consequences of acute limb ischemia in these patients are catastrophic. Perfusion strategies have been well described in the literature, and importantly, perhaps most importantly, protocolized care of the access limb is critical to save legs in these patients. Thank you for your time.
Thank you very much, Rajan, and this was truly in the spirit, the Oshner spirit, in late 90s, it reminds me, used to be the mecca for, both global interventions, cardiac and vascular in United States. And I really went back to my days of fellowship in Oshner. Thanks a lot. Stay there, and we have 2 more talks, and then we can have a panel discussion.